name is Samvrit Rao, and I'm a junior at Thomas Jefferson High School for Science and Technology, and I'm also a research intern at Harvard MIT HST at their institute there. And today I'm going to be talking about specifically multimodal AI approaches to help innovate care for patients suffering from chronic respiratory diseases using a precision medicine approach. So you might be thinking, why do you want to hear about this project from a scrawny 16-year-old standing at the front of the stage? Well, it's because of this multimodal approach that this project utilizes. So the first arm of this approach utilizes the electronic health record. So this, in the past, we haven't been able to necessarily use it because of the vast amount of unstructured data that it contains. However, in recent years, there's been development of new algorithms and new large language models that have been able to effectively parse these electronic health records and turn them into structured, modelable data. So now, this structured data can be then grouped using clustering algorithms to identify specific patient groups based on specific biological parameters, which could identify patients who could benefit from these targeted therapies. So the second arm integrates these real-time telemedicine data and machine learning-based characterization of inputs, along with prognostic matching using EHR data to identify optimal treatment responses, making this a really innovative approach. So the machine learning methodologies are implemented to identify and classify this real-time physiological information, which are then used to utilize to help make informed treatment choices. Lastly, optimized treatment strategies are provided using a meta-analysis findings and also keeping this human in the loop, keeping these physician findings and insights to target pathogenic mechanisms in specific patient clusters, enabling the creation of real-time, personalized treatment plans tailored to each patient's unique medical condition.
Hey, Samvrit, real quick.
All right, so now moving to prescriptive analytics. So you might be asking, what exactly are prescriptive analytics and how do we get to these individualized treatments using this EHR data? So as we know, the electronic health record is essentially a gold mine for information, as they hold vast amounts of unstructured patient care and outcome data. So in my project, I've implemented a 4-step analytical approach, beginning with descriptive analytics using EHR data and to effectively advance towards prescriptive analytics. So delving into descriptive analytics allows us to comprehend and essentially summarize the unstructured data, capture what's occurred in the past, and moving to diagnostic analytics, what enables us to understand the causality of why these events are occurring. So now, once you establish this historical context and causality, you can implement predictive analytics. So here is where the statistical models and machine learning come in, and we can forecast these future outcomes based on historical data patterns. For instance, predicting patient readmission rates or disease exacerbations as well. So by integrating these insights from all the previous stages and applying advanced algorithms, we can not only predict the future, but also shape it as well. So prescriptive analytics utilizes simulations and optimization models to recommend actions that will yield the best outcomes. For example, this electronic health record data can help us tailor treatment plans that are specifically optimized for individual patient profiles, which overall lead to better health outcomes, while also incorporating domain knowledge, which ensures that the analytics are grounded in medical realities. We're not straying away from medicine as a whole and our patient needs as well. So, why exactly should we focus on this precision, personalized medicine-based approach? Traditionally, medical treatments are kind of focused on this one-size-fits-all approach. It relies on giving similar or same medications to every person with a similar diagnosis, minus things like allergies and stuff, but this one-size-fits-all approach can lead to ineffective treatments, and in some cases, adverse reactions and even ineffective outcomes as well. Therefore, this is why we need personalized medicine. By analyzing an individual's biomarkers and biological signatures, and analysis of a large amount of historical EHR data, one can predict more accurately how the patients will be responding to these certain treatments. This is not just about choosing the right medications, but also adjusting dosages, combinations, and the timing of treatments to improve and optimize medical efficacy. So this slide also kind of details the stuff I was talking about in the previous, but essentially precision medicine leads to better disease diagnosis and increasing treatment effectiveness, and all these other things that you see on here as well, and overall streamlines the drug development for specific patient groups. So now I want to talk a little bit why I wanted to focus on COPD for this kind of methodology. So the World Health Organization has reported that approximately 1 billion people worldwide seek medical attention for respiratory diseases, and tragically, millions of people die each year due to these conditions. One of the leading causes of death within respiratory diseases is chronic obstructive pulmonary disease, or COPD. So the CDC describes COPD as a heterogeneous lung condition which can be caused due to, in part, any of these factors you see on the screen, characterized by things like difficulty breathing, coughing, and fluid filling in the airways. Unfortunately, traditional one-size-fits-all treatments fail to prevent exacerbations in most patients. But why? This is because each patient's COPD journey and underlying problem is unique and can be a combination in due part, as I said, to any of the following factors. So the multifactorial pathogenesis of COPD underscores the critical need for precision medicine in the treatment of this condition, as standard drugs often fail to address the unique complexities of each patient's condition. So to untangle this heterogeneity of COPD, I use data from the BIDMC MIMIC3 clinical database, which contains over 2 million data entries, including outcome data and clinical notes as well. So now moving into the methods of this.
It's still on the screen.
Yeah.
Did your screen go black on your end too?
I think it's just a projector for the turn on. Something. You can just turn that on. Beep and then I heard it click.
Yeah.
It's just a beep in the screen.
Okay. I mean, for the people in person, I guess, on your laptops, you can still see it.
You can get
Or on your
over.
phone, yeah. Sorry about that.
Sorry about the technical difficulty.
Yeah, I think you guys have a moment to pull it up. A minute or so.
Should be good.
Good. All right. So now I'm going to be moving on to the methods. So pretty much the main thing that I did was harnessing the electronic health record from the BIDMC database. The goal of my project was essentially to decode the disease's complex spectrum, cluster patients into their unique groups with similar characteristics, and create a personalized precision medicine tool that will suggest tailored treatments and minimize exacerbation events. So engaging with data scientist mentors at Harvard, MIT, HST, partnering with pulmonologists, and utilizing predictive analytics and domain knowledge, I sought a solution to essentially optimize these treatment strategies and improve outcomes. So electronic information from the electronic health record can be extracted using large language models, and due to their recent popularity, there have been large language models specifically tailored for clinical use cases. So one of the leading contenders in this field is the RAIMBDA large language model, which has been trained on PubMed, PMC, and the actual MIMIC-3 clinical database, making it ideal for this analysis. So the model was fed in all the nodes pertaining to COPD, and based on topic knowledge, identified over 100 features that are related to the condition. This was then further narrowed down to 15 key features based on a recent meta-analysis that was done by, I think it was GLBIO et al. So each node was then thoroughly examined based on the LLM's content knowledge, and a 0 or 1 was reported for the binary variables, say presence or absence of diabetes, and a specific value was recorded for the discrete variables, say like 63% for the forced individual volume, and all of this was done by the large language model as well. And so these features were then aggregated for the entire study and analyzed to understand the grouping better. So here is kind of the result of that first set of analysis, which is highlighting the total number of patients, number of males and females, and the demographic characteristics and COPD-associated features, as I was saying, like smoking, diabetes, cardiovascular conditions, all which are associated with the condition. So following the pre-processing of the data, the 8,300 patients were then clustered into groups through K-prototype clustering. So K-prototypes is a unique clustering model because it utilizes both the clustering of categorical and discrete variables, which is really novel in this case and kind of required because of the amount of features which are both categorical and discrete in this analysis. And so the clusters were created based on the aforementioned 15 features, and the discrimination was most prominent within the clusters for features like FEV1 and breath sounds, both of which were very varied in the clusters as a whole. So the groups were then stratified, and the importance of the features was then quantified using principal component analysis. So these features were then given a higher weightage going into the predictive analysis model to predict the most optimal treatment plan for each patient. So this was split into an 80-20 train test split and was built on a random forest framework that utilized Bayesian optimization. So the performance of this model was quantified through AUC, ROC curves, and the PR curve, and so using data related to the presence or absence of exacerbations and other treatment options data as well, the random forest model was built to predict the most effective treatment plan for each individual that prevents the occurrence of exacerbations. So the model was given as an input for each of the 15 key clinical features were fed into the model, and it was asked to predict the most optimal combination of existing treatments for COPD, such as corticosteroids, short-acting beta agonists, long-acting beta agonists, mucolytics, and anticholinergics. So it was asked to predict either a 0 or 1 for each of these. So a 0 was representing an absence, and 1 was representing a presence of the specific drug. And so another thing to note is that with the inclusion of FEV1 and breath sounds, the AUC was approximately 7% higher than without it, which shows the kind of importance of these features in this analysis as well. So now moving into the real-time prognostic matching, which is one of the most novel features of this analysis, is that when diagnosing and selecting treatments for patients with COPD, the two key features that are considered by pulmonologists, so it's kind of the incorporation of the domain knowledge into the model, were FEV1 and breath sounds, which were the same features which are identified through the principal component analysis that defined 3 different clusters that were identified. So the way to utilize these two features for preventing exacerbations was to employ a telemedicine-based approach to capture these features during an exacerbation, and also utilize like machine learning-based algorithms to identify and utilize these inputs for further analysis downstream. So the prognostic matching layer involves the analyzing individual patient data to predict disease outcomes and treatment responses as well. So this data-driven approach of both incorporating the real-time data and the prognostic matching while keeping the physician in the loop throughout this whole process allows providers to tailor treatments based on the projected progression of the disease based on this real-time data, maximizing treatment efficacy. So following the clustering of the patient groups, predictive analysis using causal data, the prognostic matching using real-time breath sounds, and FEV1 data, it was now time to incorporate this domain knowledge from physicians. So for this purpose, a decision matrix for monotherapy or dual therapy was incorporated into the model following matching to ensure the underlying pathogenic mechanisms, whether it be inflammation, constriction of the airways, or fluid in the airways, and excess mucus would be adequately tackled. And figure 4b here also shows the highlighting similarities of the node within the Euclidean space, which was measured through cosine similarities. So essentially, the nodes, there were a lot of nodes that had similar nodes with patients with similar characteristics within the same cluster, which was incorporated into the prognostic matching algorithm. So following the prognostic matching, the follow-up predictions showed that the occurrence of exacerbations in COPD would be half using the personalized treatment options recommended by the Breathwise model in comparison to the standard treatment that was followed by the patient, or by the physician. So not only does the prescriptive analysis for the Breathwise model improve care for the individual patients with COPD, but also has a profound impact on the overall healthcare delivery workflow. So it leads to improved care with patients with respiratory diseases, helping clinicians monitor treatment efficacy remotely, enables the implementation of single-subject clinical trials, which can be done in silico, and also significant cost savings and improved efficacy of the care for patients with respiratory diseases in primary care as well. So kind of going into the explainable AI aspect of this workflow. So a patient who's already on treatment for COPD who is experiencing an exacerbation can utilize the Breathwise tool to capture this real-time data. Real-time data can then be used to update the electronic health record and serves as the input for the Breathwise platform. The optimal treatment plan is then identified through the process of clustering, predictive modeling, and prognostic matching, and all information, including the updated EHR, is sent to the physician, enabling them to incorporate their input into the treatment plan as well, enabling patients with COPD to receive the most optimized treatment plan for their individual needs. So I'd like to thank the lab members of the Clinical Data Animation Center, the pulmonologists who I consulted throughout this project, Dr. Duclair and Dr. Barlin, my mentor at school, Dr. Kathleen Morrow, and if you, any virtual audience or even people in the in-person audience as well, if you have any interest in anything or just wanting to contact as well, this is my email, and yeah, also connect on LinkedIn as well, saying my name is Samvrit Rao. But yeah, thank you so much.
Good talk. There were no questions online. Any questions in person?
Yeah.
Very clear presentation, so good job. You're projecting really well. I can really clearly understand everything you're saying. So you're using, it sounds like, or you proposed using different modalities of data, so like EHR, structured data that you're extracting with NLP algorithms. You're going to use like telemedicine data that I'm guessing you're still going to need to extract structured data from.
Yeah, so for that aspect, it's like auscultation of the breath sound specifically, which can be done through like an electronic stethoscope.
Okay.
So when you do that, there's been quite a bit of literature that's been out already about utilizing machine learning algorithms to classify these breath sounds, which are really important to pulmonologists when they're making their prognostic and diagnostic decisions. So when you can use those algorithms to classify, it makes it a lot easier for the physician, which kind of goes into their overall treatment.
For sure. I could see like the parallel to blood sugar monitoring, like automatically, things like this, what devices that can, talk to an EHR, which is really cool. But my question was, because you want to use multimodal data, are there other data sources that you think that could harmonize really well with inputs into these algorithms that maybe would improve things like your, AUC for your precision recall curves and your ROC?
Yeah, definitely. So I think that one of the things to know with the AUC ROC curves is that it's using a random forest right now, which is a binary classifier. And since it has to predict essentially 6 of these treatment plans correctly to register like an increase in the AUC, that's why it's not like 0.9 or 0. Above that threshold, because for each individual one it was like around that level, but then for the specific, like all 6 of them combined, it was like 0.78, 0.76 as well. But I think another thing that could potentially be used is maybe MRIs and like CT scans as well, especially the ones that are done of the lungs. Because you can use these image analysis and algorithms as well that can be used to classify different things like pleural effusions and stuff that we can see on these scans. That's one of the modalities as well, but I think that there's a lot of potential, especially with the new and up and coming into the large language models as well. So we're kind of only scratching the surface with the EHR. There's a lot of stuff in there.
Do you have any ideas of how you would integrate those different kinds of data sources together for use and as input into your model?
I think that, so having worked a little bit with Epic as well, I know that Epic has like different scans and stuff that are incorporated into the model and into the application as well. And the EHR is also obviously built on Epic as well. So I think that could be a potential avenue for it as well, being incorporated directly into Epic, which contains a repository of all this stuff. And I think, that's my initial thought process, but I think I would be open to further discussion.